Are you able to hear me?
Yes, I can hear you.
What I was thinking is maybe I need to cut down my presentation because there are a lot of questions.
Okay, well, we've already started. It's after 6. So welcome everyone to TMA's Ask the Doc webinar series. My name is Rachel Bromley, and I will be your host this evening. I am TMA Senior Manager of Patient Education, Support, and Advocacy. And tonight we have the honor of speaking with Dr. Rohit Aggarwal. Dr. Aggarwal, thank you for being here.
Sure. Thank you for inviting me for this Ask the Doc. I actually have a small presentation, but when I saw the number of questions the patients have, I thought maybe I need to cut down the presentation.
Oh, we won't be able to get to all the questions for sure.
Yeah.
We'll have questions in the Q&A box, which if you have a question for Dr. Aggarwal, please put it in the Q&A box. And then we have those that you have submitted, and we'll get to as many of them as we can.
Yeah.
But let me do your bio real quick before you start your presentation. Dr. Aggarwal is a professor of medicine at University of Pittsburgh and medical director of Arthritis and Autoimmunity Center at University of Pittsburgh Medical Center. He is the co-director of UPMC Myositis Center. His research and clinical areas of interest are clinical and translational research in inflammatory muscle diseases and associated interstitial lung disease. He is the immediate past chair of the Medical Advisory Board of the Myositis Association, as well as past chair of the Scientific Committee of IMAX, which are the largest patient and physician groups working in the field of myositis, respectively. And I'll just cut the bio short right there so we can have more time for questions, if that'll work for you. But go ahead and let's start with your presentation.
Yeah, give me 1 second. Just pull up. So I'll start the sharing. Okay, here you go. Are you able to see the presentation?
Yes.
Okay. I just want to, maybe I landed on the wrong one, huh? Do you see the Myositis Association on the top?
I do.
Okay, perfect. So it's Ask the Doc. Okay. So as you may already know, I do a lot of work with patients. I've been associated with TMA for, I don't know, almost more than a decade now. But I have a short presentation, and the reason for the presentation is also to make you understand that maybe what direction of my research I'm trying to take, and it's very patient oriented. So I thought I will give some presentation on that. So first of all, as you may already know, myositis, the technical name of myositis is idiopathic inflammatory myopathies, or we call it as IAM. It has a various different subtypes. We have polymyositis, necrotizing myopathy, antisynthetase syndrome, dermatomyositis, clinically amyopathic dermatomyositis, then juvenile myositis, cancer-associated connective tissue diseases, myositis, and infusion body myositis. Typically, myositis is an autoimmune disease that affects multiple organs, but the primary target is muscle and or skin, and in often many cases is lungs. One thing that I want to emphasize always to my students and everyone, that myositis affects multiple organs. It's not just muscle and skin, all the muscle and skin itself. It could be quite devastating for our patient, but it also affects lung, joints, fingertips changing color called Raynaud's, difficulty in swallowing, and something called calcinosis, where you get calcium deposition under your skin. Up until recently, there were no FDA-approved therapy for myositis. Fortunately, in June 2021, less than a year ago, we were fortunate to have our first phase 3 clinical trial on IVIG in adult dermatomyositis positive, which led to FDA approval in dermatomyositis for IVIG. So we have one FDA-approved drug which is proven by phase 3 data in myositis now. Now, what I want to talk to you about is a different way of doing research, and I will explain you how we do research and how I would like to change how we do research, and would love some feedback. I'm just showing you a slide from rituximab in myositis study. This was a large study of 200 myositis patients from 2005 to 2013. It took 8 years and almost $8 million to complete this study. And we looked at the results, and there was no difference in the two cohort. Now, we do believe that the rituximab worked for myositis, but at least the study was negative. Now, to me, this is a very inefficient way of doing clinical trial. You spend 8 years, $8 million, and in the end, you have a negative study. So I want to change how we do clinical trials. And the problem with the clinical trial is they're long and painful process, and it's very expensive. It's anywhere between 20 to $80 million. But if you look at why does clinical trial take so long, and why are they so costly? The part of the problem is that rate limiting step is access to patients, specifically in rare disease. Because myositis is a rare disease. What happens is, even if I have 50 sites across US and Europe and other places in the world, I only can target up to 3% of patient population, because you can only go up to 100 to 200 miles around the area you live. So it's a big problem, and that leads to slow trial, and that leads to a lot of money, because longer the trial going to run, one, you're losing time to help patients. The second is we're losing money. Third is, we're losing effort where we could spend on other things. So the reason for that, as I explained you, we do trials where we do center-based trial, where we select patients from in and around the centers. And as you see in this figure, we get patients from in and around the centers, and we put the data together to learn something. But I want to change that. That's a traditional model of clinical trial to more patient-focused model of clinical trial, which we use using telemedicine. In this kind of model, you have one center which are coordinating between many patients across the US or Europe or the whole world, where basically it's anywhere. You could be anywhere with the help of internet if you need to have an internet. But if you have internet, then you could be enrolled in the study. So we want to change the model from the center-based model to more patient-based model. And in this model, what happens is that everything is centered around the patient rather than centered around the center. That means we go to the patient's home and get everything done through the patient's home with the help of the patient, obviously, but it's a more effective model according to me. To study this model, I got a grant from NIH. We called it as Myositis Patient-Centered Tele-Research, or MyPacer study. And some of you might actually have helped in this study. Obviously, I can't tell who's in the audience, and I'm very appreciative of all those who were part of MyPacer study. And TMA was one of the major partner in this study. TMA patients who were member of the TMA joined the study above and beyond than any other organization that helped us. So one of the aim of this study was to understand the effectiveness of tele-research cohort, the cohort that I'm talking about, the new type of cohort, by using smartphone technology, wearable devices, and telemedicine, as compared to traditional site or center-based cohort. And we wanted to study, can we do better patient recruitment, better subject retainment, better data compliance, and so on. And so we had a center-based cohort, which was two centers. One was University of Pittsburgh, second was Cedars-Sinai. And then we have what we call a tele-research cohort, where patient could come in from any corner of US. And what we did is we got the help of myositis organizations like TMA to spread the message and go to patients, email them, go on social media, Facebook, Twitter, and tell them about the study. And that's what they did. And once they know about the study, the patient who are interested could click on the link, which will take them to what we call as a landing page, or they can download an app and can know more about the study. If they like to do the study, then they can join the study through an app or the website. And once they join the study, they have to do certain activities on a monthly basis for 6 months. And all the data is collected remotely into a database, and then we do analysis on it. And all the study procedure is done remotely or virtually, including from recruitment to subject verification to consenting, patient history, in this case, we did not have drug delivery because it was an observational study, but we could do drug delivery to patients' home, safety monitoring, outcome assessment, and database management. All of them was done remotely. So this is just an app and a website that we use for MyPacer study. We did pre-screening, which means we screen the patients even before they join the study to see they are eligible. We did consenting through app and website. We even had the real signature of the patient on the app, so it's sort of more legitimate. Everything was HIPAA compliant, which means the privacy issues were taken care of. And then we reviewed medical records. We got their medical records and reviewed the information that patient provided to make sure that is an accurate information. Following that, we did telemedicine visits with our patient to get further information on our patients. And then we used a lot of devices, including physical activity monitor like Fitbit. So we send Fitbit to patients' home to collect the remote data on their activity. And we can collect a lot of different variables on Fitbit, such as, how much do they sit or walk or run? How much do they go from one place to another place? Are they active, minimally active, moderately active, and so on? In the end, we looked at the comparison. We got 70% females, mostly were white patients because of our demographic. Age range was wide. We got young patients to all the way to 78 to 80 years old patients. So it wasn't like only young patients joined the study. Actually, a lot of my patients were, in their 60s and 70s, and they loved the study. And we enrolled patients for dermatomyositis, polymyositis, and necrotizing myopathy. But the most important part that I want to show is this result. This is the blue line is a center-based recruitment, which means number of patients wanting to join the study. And the red line is center-based. And the blue line is a tele-research cohort. Within a month or so, we had 600, 700 patients who were wanting to be part of this study. And this was very encouraging because our target enrollment was only 80 patients. And we got like 6-7 times more patients who wanted to be part of the study. So this was very, heartening and very encouraging for me personally. And then we showed that tele-research method is actually far better than a center-based method. And we looked at the enrollment rates were far better in tele-research cohort as compared to the center-based cohort. And even the data completion and study completion and dropout rates were very similar. Tele-research cohort did as good as a center-based cohort do in terms of study completion and dropout. So in conclusion, what we concluded in the study that recruitment enrollment rate of a virtual tele-research cohort was far superior than a traditional based cohort with similar screen failure and retention ratio. And we want to use this virtual technology or the system for doing future studies, including clinical trials. So with that, that's the direction I'm taking for any of my future studies or clinical trials that I'm part of. Now, it takes time to bring the change. So generally, medicine, healthcare is about 10 to 15 years behind the technology in terms of bringing the change. And in clinical research, unfortunately, the time is even more. To bring change in clinical research take time. So, for example, even now, most of the clinical trials I'm doing are traditional clinical trials. There's only one clinical trial I'm trying to do now, which will be completely remote. But once we do one and show that that's successful, that may lead to 2 and then 4. And that's how we kind of try to bring change. With that, I would like to thank you from Pittsburgh Myositis Center. I know you have a lot of questions, and I'm ready to hear from you, your thoughts and questions, and we go from there.
Thank you. One of our questions about the telestudies is, could patients in Canada be included in telestudies?
Yes. The reason we do US is because of the regulatory reasons. So if we do consenting in US, I can enroll patients from anywhere in US mainland, and patients can consent. If we do include Canada, then we need additional center in Canada and then do consenting through that. So it becomes little limiting. So we are taking step-by-step measure. So first we are doing pan-US studies. And once we prove that successful, then we will go to the Canada. And then hopefully the people in the same time zone. So Canada, Mexico, and South America is our next target. Once that is achieved, then we'll go to the, Europe and other countries. That's the whole. I mean, it takes time, and you can only show incremental benefit. So
okay. And someone, go ahead.
No, somebody was saying something.
Yes, they wanted to know if their current regimen is working well. Should they go ahead and sign up for the study?
So the study is over. This study is over. But I
Okay.
would like to know the interest in a follow-up study. What we are trying to do, there are two things we are doing, which will be of very much of an interest to our patients. One, we are doing a clinical trial that will be starting in about 3 to 6 months. This clinical trial is for patients who have interstitial lung disease and myositis. Those patients can join this trial, and that trial will be completely remote. So anybody in any corner of US can join the study. Now, having said that, but that's a clinical trial specifically. That means there will be a drug involved. So you get the drug or placebo, and then everybody gets the drug, and details of it will be out soon. But another study that we are doing, which anybody in the world can participate, is MyPacer 2. This was MyPacer, and this is the second one, is a version 2 of it, where we will enroll patients for observational cohort, and they can join the study, they can provide their data, and they will be followed for every 6 months, as long as we can run the study, basically. And that's the study that we will hopefully start by end of the year or so. We're still developing infrastructure for that. So those two studies, anybody technically can participate.
Okay. Do virtual remote clinical trials have issues with funding when conducted this way?
I think funding is definitely one of the barrier, because companies and people don't want to put money on something which is not been a traditional way. So in other words, when you show something novel, the acceptance rate of novelty is low because they're not sure if it's going to work, right? So that's the part we are trying to do, is we're trying to show one by one that this will work or may work. And once we show that, then the funding becomes easier.
And MyPacer 2, will you have any IBM patients?
Yes, that's another point. In MyPacer 1, we did not have IBM patient. In MyPacer 2, all type of myositis are included, including it. I think juvenile patients cannot be included, but juvenile myositis patients who are adult will be included.
Okay. I'm looking in the Q&A for our next question. Could stem cell therapy be beneficial for myositis? What could be the upsides and downsides?
So the stem cell therapy, the biggest problem with stem cell therapy in myositis is that it itself has a high mortality and morbidity associated with it. Because of that, stem cell therapy currently is only recommended in the worst of the worst case. In other words, when everything has failed, even the trials have failed, and only then I would even recommend somebody for stem cell therapy. So typically, we're not going for stem cell therapy just because of the toxicity profile is very high in patients with stem cell therapy. But hopefully, there are other drugs that are coming up which are not truly completely stem cell, but what we call them as a CAR T therapy, and other therapies are coming up in oncology world. And some of those treatments are applicable to rheumatology or neurology or myositis. So we are trying to study that part. But a complete stem cell therapy, it has a high toxicity, so we don't recommend it right now.
We have somebody saying that they had never seen the published results from the arimoclomol clinical trial for IBM. Was there any positive news at all from this trial, even though overall it did not meet primary goals?
Well, I think there were positive signals in the trial. Now, I think you're right, it hasn't been published, but I can check on that. I think it's going to be published soon. Arimoclomol was going to be published soon. I know the manuscript was being worked on. So let me see. Yeah, it hasn't been published yet, but it should be published soon. But having said that, at least everybody agreed. I was part of a panel where we were discussing these results, and everybody were agreeing that at least, even though the study is negative and this drug may not be used for future, but the pathway of arimoclomol seems to have enough signal that the next step, another company or a different compound from the same company could take.
Okay. Let's see. Can antisynthetase syndrome be managed and patient become normal again, or is this just going to be progressive over time?
No, I mean, there are patients from all walks of life in antisynthetase. I today saw a patient of mine who, believe me, just comes every 6 months to see me. Yes, he has no need to come and see me. He's absolutely normal. His lung function capacity is better than mine, probably. He is healthy as a horse can be, and he has no symptoms at all. And he's been off treatment for now 2 years, completely off treatment. So there are patients like that. And there are patients who I am sending them for transplant. So there's a whole spectrum, and one size doesn't fit all. It depends on where you are on the spectrum. So there are many patients who are able to achieve off treatment remission. About my numbers are about 10 to 15%. And another 10 to 15% are able to achieve on treatment remission. So there's a lot of positive news there. Now, obviously, some patients progress despite of we do anything. But there's a whole spectrum of patient, and I would not be discouraged if you have a diagnosis of antisynthetase, this is the end of it. No. I mean, I have I've taken off treatment many patients of antisynthetase syndrome.
That's wonderful news. What can I do or fail to do to avoid another myositis flare-up?
What you can do is, the best treatment I tell patients that they can do is exercise. Because exercise is not only building your muscles up, but it's actually anti-inflammatory for muscle. So I tell them, if you could do something for yourself, continue to do exercise.
And some of the questions that have come in are very personal and dedicated to one person's particular situation, and we can't cover those. I regret. We need to focus on questions that have a general appeal to the audience, especially if you're like giving me lab information and things like that. That we can't cover that here. Let's see.
I have a question here. Is antisynthetase syndrome with organizing pneumonia type of ILD? Yes, it's a type of ILD.
Okay. You mentioned that myositis can affect organs. Have you seen heart muscle impacted by myositis?
Yes, it's actually seen that up to 10 to 30% of myositis patients can have their heart muscle involved. So that's quite a large number. But fortunately, only 5% or so actually have symptoms from heart. So heart involvement is, I mean, depends on how you call 10 to 30% is there, definitely there. But fortunate part is that symptomatic heart involvement is quite rare, at about 5%. But yes, to answer, yes, it can involve heart.
Mm-hmm. Can myositis worsen a pre-existing neuro condition like epilepsy?
That's a good question. Honestly, I don't know the exact answer, but I have never seen it that myositis is worsening another neurological condition. Now, sometimes we call it a double hit. What double hit means is they have a neurological condition and they get myositis. So now it's like a double hit, because they already have their muscle weak, or they have problems with their muscle to begin with, and then they get myositis. So that can actually increase the problem for the patient.
You mentioned exercise. What type of exercise would you recommend?
That's good question. So on TMA website, by the way, has quite a lot of exercise given. So I would follow that. The second is the exercise. There are two types of exercise I always recommend. Depend on what you have. If you have IBM or you have non-IBM myositis. So for non-IBM myositis, the exercise of the deltoid muscle, the proximal muscles, and the hip area muscle, which is iliopsoas and gluteus medius and maximus muscle, are the most important exercise to do. And so that's one type of exercise. But another type of exercise you can do is what I call as functional exercise. In this, you basically look at what functional deficit do I have. So let's say a patient has a difficulty in getting up from a chair or going up the stairs. So what they do is they do that exercise repeatedly. So we do something called sit to stand. We ask the patient to get up from a chair, sit back down, then get up from a chair, sit back down, continue to do that. That itself is a good form of exercise for patients who have functional difficulty from getting up from a chair. Same as going up the stairs. Anything where you have a functional deficit, if you work on it slowly, it will improve. Now, for IBM patient, it depends on where is the weakness. So if they have hand weakness, they need to do hand exercise. If they have shoulder weakness, they need to do deltoid exercise. So it depends on where their weakness is. But TMA is a great resource for exercise.
Okay. When you were talking about heart involvement, did that pertain to all types of myositis?
Mostly heart involvement. I have not seen the heart involvement in IBM, honestly. I've seen it mostly in necrotizing myopathy as most common, sometime in antisynthetase and sometime in DM and PM, but most commonly I've seen in necrotizing myopathy.
Okay. Do you think nutrition or any vitamins and or supplements can help with different types of myositis?
Not really. What it really helps is to have a good diet. So, for example, patient who's on steroid is going to have weight gain. If they take a diet which also will lead to weight gain, is a problem. So they need to have a more lean diet. More protein-based diets are better because that way you're getting a sufficient amount of protein and less amount of carbohydrates and fat. But you need to have enough energy in carbohydrate and fat as well. But there is no specific diet recommendation. Diet has never been associated with myositis overall. Supplementary vitamins, what I recommend is if you are deficient on a vitamin, let's say you're deficient on B12 or vitamin D or whichever vitamin, you need to supplement that. But general multivitamin without any cause may be helpful for you in general, but doesn't affect myositis.
Okay, I'd like to remind everyone, please put your questions in the Q&A. That's what's being monitored the most. The chat is more for individuals to speak to each other. I might be able to get a chance to look into chat here in a little bit, but if you could put your answers in or your questions in Q&A, that would be helpful. Dr. Aggarwal, how often do you see antiphospholipid antibody syndrome in dermatomyositis?
It's seen, but it's rare. I have few patients with it. It's rare enough that I do not routinely check antiphospholipid antibodies. However, I have seen some patients where this was a problem. In fact, antiphospholipid antibody can be associated with any autoimmune disease. Most commonly, it is associated with lupus. But since myositis is also an autoimmune disease, it can affect myositis patients as well.
We have some COVID questions, but I'm going to come back to those in a little bit. Can you speak to the role of vasculitis in autoimmune myositis?
Yeah, so vasculitis is a very interesting phenomena. So first of all, we believe that dermatomyositis has a component of vasculitis. And we know this for sure in juvenile myositis, because we see in juvenile myositis, there is a clear-cut evidence of small vessel vasculitis happening in dermatomyositis. So some component of dermatomyositis is definitely acting through vasculitis component. So yes, to answer to that is, if within the pathogenesis of dermatomyositis, there is a significant vascular involvement, and that vascular involvement is much more common in dermatomyositis and even then more common in juvenile dermatomyositis. We still don't understand exactly how dermatomyositis involves vessel and lead to vasculitis per se, but there is clear evidence that vasculitis has to play a role in it.
How can a patient tell the difference between a flare and prednisone withdrawal symptoms?
That's a great question. I wish I had a good answer, but this is something that all patients and doctors struggle with. I'll tell you a simple rule of thumb. So what happens is, when you first of all cut down the prednisone slowly, because each time you drop the prednisone, your body isn't getting that much of steroid, and the body doesn't like not getting the steroid. So body sort of kind of, feels like pooped out, completely, like, feels like lack of energy when you take away a little bit of steroid. So the idea is, first of all, go down on steroids slowly so that each step is not a big deal for the body to recover. That's number one. Now, if you do that, and if you feel generalized weakness, overall you feel weak, then that's likely from the steroid. But if you feel weakness in particular muscles, specifically the muscles of shoulders and hip, then it's more likely to be the disease flare effect. And also disease flare can also lead to, for example, rashes or joint pains and things like muscle enzyme going up. So there could be other evidence of flare up.
I know that causes are still vague and are for the most part unknown, but can environmental factors trigger IBM?
IBM is very interesting. There are many environmental factors that have been implicated. None of them has been proved. For example, Agent Orange has been implicated in IBM. HIV has been implicated. Many adenoviruses have been implicated. So there is a possibility, even in polymyositis and dermatomyositis, there are a lot of viruses that believe that they could trigger the autoimmunity and lead to the problem. So the question that we are facing is, one, we are unable to prove any of these environmental factors or infectious factor because the studies are tough. I mean, I don't know if it's a deficiency of study or we're not able to prove because there is no connection. So that's number one. Number two, the connection is also of two types. One type of connection is that you get an infection or you get an antigen or an environmental factor that doesn't cause myositis, that just triggers your autoimmunity. Because you have an autoimmune milieu or sort of the right infrastructure for myositis, when autoimmunity is upregulated, it leads to myositis. So that's one theory. Another theory is it directly leads to myositis. So not only we're not sure about the link, we're also not sure what the pathway is. And these studies are very, very difficult to conduct.
Does having DM make someone more prone to muscle and tendon tears?
If they are weak, then yes, that can happen. You have weak muscle, you putting a lot of pressure on weak muscle, it's mechanical, that can happen. Does it happen commonly? No.
Let's go over to some of the questions that were submitted by email. Do you see eye health issues with myositis, such as detached retinas?
Not really. Eye health issues, whenever I see, is secondary to steroids, like cataract, glaucoma, and other problems are secondary to steroids or medication.
Are you familiar with the Grail blood test to assess cancer, especially concerning for us with TIF1 gamma?
So TIF1 gamma is an antibody, which is very helpful. And we recommend to test myositis antibodies in all our myositis patients. So if you have TIF1 gamma positive myositis antibody, that means that you are at a high risk for cancer. And that doesn't mean you have cancer. That just means you're at high risk for cancer. So what we recommend is extensive screening for cancer if that happens. So you do screening at baseline, then you screening at 1 year post-diagnosis, 2 year post-diagnosis, and 3 year post-diagnosis. After 3 years, there's not much of a risk. So if you're already past 3 year mark from your diagnosis, you don't have much of a risk. But up until 3 year, your risk is high and your doctor should be doing yearly screening.
How can one move themselves into remission or know when they're in remission?
So remission, the way remission is defined is one we call is, first we try to achieve remission on treatment. And once the patient achieves remission on treatment for about 6 months to 12 months, then we try to cut down the medicine to see if we can get remission off treatment. So first of all, what is remission? Remission is not very well defined in myositis, but the definition that we use is that what we call as near normal. So if you have a near normal strength, near normal skin rashes, and near normal muscle enzyme level, and near normal function back to your baseline, that's what we call as remission. And also you're not required any escalation of your immune therapy in last 1 year.
Another person asked, what are the possible medications for polymyositis?
Oh, there are a lot of different medications. So for example, we use medicine like methotrexate, azathioprine, Ivig, rituximab, mycophenolate, tacrolimus. These are all the, sometimes we use a medicine called Actar gel. We use a medicine called abaracept. So these are all the medicines that we could use. Note that none of these medicines are FDA approved for polymyositis.
We have someone who's interested in doing cupping therapy, but they are worried that it might cause a possible blood clot since they are on Xarelto.
What is cupping therapy?
Cupping therapy is when a massage therapist uses like a glass suction, and like you often see it with the Olympic athletes. They have those circles on their backs, like the swimmers and stuff. That's what cupping therapy is. It's like suction on the muscles that is really intense.
Yeah, I honestly, I don't want to speak about it because I just not have enough knowledge about it.
Okay.
If it's equivalent to a massage therapy, I see no problem. I have patients who get massage therapy because their muscles get tight and it helps them. So I'm not against it. I just don't want to speak about cupping therapy specifically because I just don't have the knowledge what it could do.
Okay. Someone here is newly diagnosed with ILD. They also have arthritis, polymyositis, and scleroderma. They have quite a bit of muscle pain and swelling, especially in ankles, arms, and wrists. They tried several different arthritis creams to relieve the pain with no success. Is there anything you would recommend?
Yeah, so depends on if you have ILD and you have all these symptoms, then what are the main medicines? The main medicine is immune suppressive drug. So you need to be on one of the immune suppressive drug to kind of control your overall symptom. Symptomatic management with ointment and cream is only going to affect you a little bit, but the main thing is to control the disease. So you need to have, medicines like mycophenolate, and other medicines to see if the disease can be controlled per se.
Okay.
And then the arthritis would automatically get controlled because underlying disease is getting controlled.
Okay. I've had infusion therapy every 8 weeks for 2 years. How long can I remain on this therapy regime? Are there any long-term side effects?
Are you talking about, I think you might be talking about IVIG.
Yes.
It's tough to know because there are different types of infusion.
Okay.
So first of all, IVIG can be used. I have patients on IVIG for 5 years or more. So IVIG can be used for long term. The only problem is that if you're doing well on IVIG for 1 to 2 years, then I try to taper patients off IVIG slowly. So what we do is we go from 8 weeks to 10 weeks, every 10 weeks, then we go to 12 weeks, and then sort of slowly get them off therapy and see if they truly need IVIG or not. Now, some patients do need it. So in those cases, we continue for another year and then we try again. So it's a continuous process. It's tough to say in a particular case unless until I see the patient. Like if somebody's doing great, my regimen is to kind of slowly cut down on IVIG dose and increase the frequency and see if they truly need it or not. Because it's an autoimmune disease. So what happens, one fundamental concept I want to explain everybody. What happens is these are autoimmune disease. So that means these are caused by our own immune cells. Okay. Now our immune cells, if we have bad immune cells, they are constantly being replaced in our body. Now it takes time, but since they are being replaced in our body, if somebody is doing great for a year, you have to cut down their immune suppression to see maybe they are gone into long-term remission now. That's the only way to know they've gone into long-term remission, because since they're replacing the immune cells, maybe the next cycle and by cycling, they now don't have those bad immune cells that could cause the disease again.
Okay. We have a couple questions about injury. Does the immune system respond by kicking into high gear? This person had IBM for the last 22 years, very slow progression until I sustained a fall with a fracture, and it seems the disease suddenly picked up speed. Is there a correlation?
Yeah, I don't. So it's a very good question. Actually, we see this all the time. What they observed. That what happens is patient has a fall. They were doing great, but the fall is taken care of. But now their weakness is a lot more than what it was, and there are explanations for it. What happens is when you get an injury, you cannot exercise that part of the muscle. So what happens is, because you have an underlying disease, you go down very fast in terms of that muscle recovery. And so in a normal person, if you have an injury, even then there is a muscle weakness. In a person who has IBM, that muscle weakness is like 10 times if they have an injury. So we always tell my patient, do not fall, because that's like the worst outcome you can hope for yourself. Because when you fall and you break something, it's one problem is to deal with a broken bone or something. The other problem is to deal with a weak muscle. And the area where you fell or you have a problem will be a lot more weaker now, even after recovery.
Why do many doctors say that with DM or PM, there really is no pain, or that you should not have pain?
No, that's not true. We did a study on pain, assessment of pain. And what we found is that about 20% patients actually have severe pain, and about 20 to 30% patient actually has moderate pain. So we found that almost 40 to 50% patient had moderate to severe pain. Now you can see glass half empty or half full, like 30% patient had no pain, another 20% patient had very minimal pain. So it's true that many patients with myositis would not have any pain, but it's also true that the patient with myositis can have moderate to severe pain. So let me explain you about pain a little bit. There are 2 or 3 different types of pain, and it's important to differentiate for the management of the pain what type of pain the patient has. One type of pain comes directly from muscle disease activity. That means the muscle is inflamed. That means and that inflammation leads to weakness. That means they have to put that much pressure on their muscle to do a certain activity. Okay, that additional pressure or effort on the muscle, when you do repeatedly, leads to pain. Okay, that's like running a marathon. I have muscle pain after running a marathon because my muscle is not used to do this, and the patient would feel the same by daily activity. So that's a pain associated with active disease. Okay, there's a second type of pain which is associated with what we call as muscle damage. So patient has had years of disease, their muscle weakness is better, but they still have pain. And that pain is now coming from the previously active disease that had led to damage in the muscle. And that cannot be treated with immune suppressive drugs because it's a damage problem. Okay. And there's a third type of pain that happens with myositis. This is called fibromyalgia or associated fibromyalgia. Any autoimmune disease has increased propensity to have a concomitant fibromyalgia. So this type of pain happens when they have concomitant fibromyalgia. So it is important to differentiate what type of pain, when patient says I have pain, what we are dealing with. Are we dealing with pain from damage? Are we dealing with pain for active disease? Are we dealing with pain with fibromyalgia? All three have different types of approaches.
I am just reading these
Sure.
questions, and if you see any, you can jump in.
Yeah, I'm going to try.
I'm making sure that we don't have any pain questions. If I have hip surgery, how will that affect the muscles that are cut? I have IBM.
It will affect it not good, because the muscles that are cut or moved, I mean, you already have diseased muscles. So now they have gotten a second injury, again, a second hit. The second hit is very problematic. Now, it doesn't mean you cannot recover. What it means is your recovery will be difficult and you have to work double the work on the muscle to recover.
Okay, and what about using anesthesia? Let me see where that question was.
Yeah, anesthesia is not a problem in most patients as long as it's it's a short surgery or any procedure you're doing. It's not a problem in most patients.
We've got somebody who's been on prednisone a few years, but developed myopathy in their muscles all over. And since they can't take prednisone, what is the best treatment for a significant flare of DM, lupus, or ILD?
Yeah, so prednisone, first of all, this patient, what you're talking about is what happens. The prednisone is a double-edged sword. One, it kind of helps you or cut down inflammation, so it helps for the muscles to recover. But a long-term high-dose prednisone can lead to something called steroid myopathy. And once you have a steroid myopathy, there's really no treatment but to cut down or get off of steroid. And seems like this is what this patient is talking about, that the patient had steroid myopathy, so they can't take steroid alone. Again, in those situations, there are non-steroid treatment like methotrexate, mycophenolate, Ivig, rituximab, Xelgens. All of these treatment could be tried in such a patient. Now, it depends on what the specific condition the patient has and what other treatment they have previously failed.
Okay, let's talk about COVID for a little bit. What's your opinion on Everyshield, and is the recommendation still to, what was it, stop cell set 1 or 2 weeks before having your shots?
Yeah, the recommendation keeps changing, but I still ask them to hold their shot, their cell sep a week before to 1 to 2 weeks after, just to make sure they get a good immune response. And that is only if they are doing well, if they don't have, severely active disease.
Okay. I am immune suppressed, vaccinated and boosted, and have had 1 full dose of Everyshield. Am I protected enough to consider careful gradual re-entry in society, or should I continue to shelter except for medical appointments or if I absolutely need to be out?
I think at this stage, if you're fully vaccinated, even if you're immune suppressed, with general precautions, you can move out. General precautions means I would still strongly recommend to wear mask. And I mean, when they are in places where there are other people, public places. And obviously don't venture out on big parties and big events, because those are super spreaders. And so only maybe venture out with people who for them personally. So if they have an exposure, they will tell you, hopefully, or make sure that they are vaccinated when you're meeting with them. Those kind of precautions. So I don't think you need to be locked down in the home, but I think you need to do still general precautions. I would not still meet people who are not vaccinated, for example, or I won't go to big weddings and parties, and because those you don't know who's coming and who's not coming in.
Okay, have we asked all the COVID questions? Were you a proponent for Everyshield?
Yeah, I mean, I think it's a good drug. And I think this is specifically for patients who are immunosuppressed. Is a really good idea.
Okay. There's so many. One moment. Some people are on IVIG and Rituxan. Are there greater results by using both medications?
Some people need both. So I only use IVIG plus rituximab when I'm not getting a response from either one. So basically what happens is IVIG is helping, but not enough. Rituximab helps, but not enough. In those cases, I would use the combination, and it does help. It does have an incremental effect. And one more question I have, I just saw this one, is the patient has a EJ antibody and has only lung disease with ground glass opacity, but they don't have muscle weakness or mechanics hand. So rheumatologist not convinced that they have antisynthetase syndrome. Now that's not absolutely true, because antisynthetase syndrome is one syndrome which could not have muscle problem at all or skin problem at all. They could only have lung problem. In fact, EJ antibody is known to have lung only disease with antisynthetase syndrome. So my recommendation of that patient would be that they truly, actually, I would believe that they have antisynthetase syndrome and would treat it like that.
We read that antisynthetase with only lung involvement require early and aggressive treatment to avoid relapse. If the patient is clinically quite well, presenting only mild ILD, but DLCO is low at 59%, would pulsed IV steroids be suitable?
So it's tough to say what the overall condition of the patient is, but if you have no symptoms, but definite ILD, I think you still need treatment. You may not need aggressive treatment like pulse IV steroid we are talking about, but this kind of patient who doesn't have symptom, but clearly have ILD on CT scan and lung function, I would treat. I would treat it with patients with mycophenolate or maybe rituximab, maybe IVIG, maybe azathioprine. I would treat this patient, depends on their level of severity. But maybe I would not give pulse if they have literally no symptoms.
If you are not TIF1 gamma positive, should you still be tested for cancer screening? And if so, how often?
Yeah, so that's a very good question. So how often? The cancer screening guidelines are that you screen at baseline and then every year for 3 years. That's what we recommend for everybody. The difference between TIF1 gamma and TIF1 negative is what do you screen with? If you're TIF1 positive, then you have to do CT scans of head to toe, which means chest, abdomen, and pelvis, and all the other blood tests and other things. But if you're TIF1 negative, then perhaps you do not need to have a CT scans of chest, abdomen, and pelvis. But it's not a very simple answer. The reason is there are other risk factors that are other than TIF1. So if you have those risk factors, for example, if you're a male above 60 years of age with severe swallowing trouble, severe skin rashes with ulceration, that puts you into a higher category of risk. And then in that case, also I would do CT scan. So it's not an easy question to answer, but generally speaking, I would say TIF1 positive, you had to do all the tests possible, including CT scans and PET scans and ultrasounds and stuff like that. If you're negative, then you just need to do regular routine age appropriate screening for cancer. By the way, we have developed a guidelines on cancer screening for doctors. We have completed that work. Hopefully we'll be publishing it in next few months. So we will be able to give specific guidelines to doctors on how to screen patients for what type of risk factors.
Living in Connecticut, I have found that during the winter months, I start feeling more weakness. Is there anything that I can do?
The reason people feel weaker and joint pains or winter months is because just how our body works is that cold induces stiffness in muscle and joint, so you tend to get weaker. One of the ways you can fight that is by exercise. To warm up the muscle and increase the blood supply of the muscle can help you counter that.
Do you know of any medications for IBM that may be in the pipeline?
There are a couple of clinical trials. One of them is called sirolimus or rapamycin. Is the first part of the study, phase 2, was positive, And right now there's a phase 3 clinical trial going on. So that's very encouraging for patients with IBM. And there's also 1 or 2 other clinical trials that are in pipeline, will be starting soon. So all of that is a very encouraging news for our IBM patients.
Are myositis-associated antibodies like RO52 being studied for their impact on antisynthetase syndrome?
Yeah, typically we know already that anti-Ro52 antibody has higher severity for interstitial lung disease, specifically antisynthetase syndrome patients. So when we see anti-Ro antibody along with antisynthetase, we tend to be more aggressive because we know that these patients would have more problem, and we tend to use more rituximab in those situations.
Circling back to the heart involvement, how will one with necrotizing myopathy know if their heart is being affected due to the disease? What symptoms should we look for?
Yeah, so typical symptoms that we have the patients have is palpitations or skip beats, those kind of symptom. And another way we know is just they have lack of energy. So their doctor would have to do an echocardiogram that would show that their heart isn't pumping the blood too well. And in that case, those are the 2 reasons we see. But typically what we recommend is that patients have an EKG and an echocardiogram at the diagnosis to make sure there isn't any heart involvement.
I've got polymyositis questions about origin. One is saying, can it be caused by Sjogren's, and is it hereditary?
So let me take the second question. Is it hereditary? First of all, let me explain you the issue with hereditary and in a second. So what happens is that I only have 2 patients who have blood relative of the same myositis. One is a daughter father and another one is a sort of a cousin. So it's very rare to have polymyositis in 2 members of the family. In fact, it's so rare that if you have polymyositis or muscle disease in 2 members of the family, we believe that you probably have muscle dystrophy or metabolic myopathy, which are genetic in origin, than polymyositis. Having said that, autoimmune disease tends to run in family. So in other words, if a patient has Sjogren's, if a father has Sjogren's, then a son or a daughter could develop polymyositis. So autoimmunity tends to run in family, but not the same disease per se. So I hope that's clear. So in other words, if somebody has a family of rheumatoid arthritis, your first relative cousin could have lupus or hypothyroidism or type 1 diabetes or other type of autoimmunity, because autoimmunity generally runs in family, whereas it's not always the same disease though.
Okay, well, I hate to say it, Dr. Aggarwal, but that is all the time that we have. And we have so many questions. You're a very popular panelist. Thank you for being part of our webinar, and we hope to have you back.
Sure, yeah, I would love to come back and interact more with the patients. And I mean, TMA is a great organization, has helped me, and I know it has helped so many patients. So I refer all my patients for TMA. One thing I would want to say, there is a COVID survey, a COVID-2 study that we are doing. I hope most patients are able to join that study or already have joined the study. I will make a personal request it's a 10-minute survey literally. So I will make a personal request to see if you could share that study, Rachel, amongst the panelists, amongst the patients, to see if the patients would love to do that study or not. I know you've already circulated the link of that survey, but is this something that you can share again or not?
Yes, we can share it again.
Yeah, maybe in the chat, if you have the link, maybe you could share it in the chat, or if someone else has the link, maybe you could share in the chat. It would be very helpful, because we are targeting at 10,000 patients, and we currently have about 6,000 patients. So it'll be very helpful.
Oh, thank you, Chrissy. Chrissy put it in the chat for us.
Perfect. Okay, great. Thanks a lot.
Thank you.
Okay.
And I am asking everybody before you get off of the webinar there, when we close out, there will be a survey for us for TMA. If you could take just a minute or two and fill out that survey to let us know how much you enjoy the Ask the Doc sessions and what we can do to improve. Thank you again, Dr. Aggarwal, and we hope to have you on again. So we really appreciate the critical work that you do.
Thank you. Thank you for having me.
All right, well, we just finished our Ask the Doc for the evening, and Saturday, don't forget, Saturday is our Myositis Awareness Month virtual summit. It's from 11 to 6. You can register on www.myositis.org. And remember, if you can't attend Saturday, or you are like some and can't sit for that long at one time, you can always still register, and you will have access to all the content up to 30 days. So you'll be able to get to see all our sessions that we have. So we're really excited about that. We want you to join us. And also, IBMers out there, we are going back to interviewing a neurologist for our Ask the Doc next month. It'll be Dr. Namita Goyal, and that will be on Thursday, June 16th. From 6 to 7 p.m. Eastern. So thank you very much, everybody.
Bye.
For TMA, I'm Rachel Bromley. Good night.
Good night.